Hello, this is Beth Shank, and for this sub-lecture, I'm going to speak about waste optimization. This is about me again. Um, Healthcare waste is really complex. It's also expensive, regulated, and abundant. It's incredible what we produce in healthcare, and this gets a lot of people's attention. So we do throw it away, and yet where is that away? We both need to understand that physically, and we also need probably to shift our awareness to know that there is no away. It doesn't go away. It may change form, but it's often just stored elsewhere. So landfill, so municipal solid waste is often treated in a landfill or in a waste energy facility. Biohazard waste, the company we use is Stericycle, and that is for bloody items, sharps, anatomical and pathological waste. And then there's hazardous waste, and that is RCRA defined, the Resource Conservation and Recovery Act through the EPA. And that is our solvents and chemical waste, as you're familiar with, but also a fair number of pharmaceuticals are classified as RCRA hazardous. So we collect that separately. Then there's another type of waste, which is narcotics waste. That's not RCRA hazardous, but it's a chemical of concern, a drug of concern. So we collect those separately. That's under a different regulatory body, the Department of Justice, as opposed to the EPA. So waste, what we can actually see at the end of the life cycle of a product, is really a measure of our inefficiency. If we are intentionally designing systems that are going to end up with enormous quantities of waste, that doesn't reflect well on our use of resources or our reuse and recycling, the life cycle use of those resources. Also, many greenhouse gas emissions are formed through waste. And in the production of the goods themselves, as I mentioned on a different slide, but also in the disposal. So you can imagine the methane accumulation in landfills, the energy used to treat biohazardous through autoclaving or incineration, and the energy used to treat hazardous through incineration. Also, the transportation of the waste. We drive our waste in the West. There are only a handful of high-level hazardous waste incinerators in the nation. Most of our waste, hazardous waste, goes to Port Arthur, Texas. This is even from Seattle. And biohazard waste, there are more treatment facilities for biohazard, but still it's often hundreds of miles away to take it. So what is waste optimization? It's really achieving the best practice in waste management to meet targeted waste volumes. And we know about targets through some national benchmarking work and also through our own comparisons from sites to regions to states to through different waste streams. We know that a really important piece of this is segregation, and this is, again, to meet regulatory compliance. You can't put hazardous waste in the recycling bin, and also to meet environmental goals. We don't want to contaminate food compost by having a hazardous waste in there. Some of the early work in this started back in the 80s and 90s when redback waste it was realized that redback waste or infectious waste was full of all sorts of stuff that didn't need to be there, coffee cups, newspapers, etc. And so there became an effort to focus on that. And we want to take that further, of course, and really segregate each stream as well as we can. Now that's difficult. Segregation is difficult because that involves every single person out there. So in our facilities, as I've mentioned, we have 120,000 employees. It's hard to have them all segregate properly. But then you have the public coming in as visitors and cafeterias and conferences and whatnot, and patients. And so very hard to segregate waste. That's why it's really important to be clear about where things really go, messaging, signage, reminders, ongoing education, super important. So we also want to, through doing this waste optimization work, we direct everything we can into the least expensive streams that meet those two goals, regulatory and environmental. So it turns out that what we've found so far is that recycling and composting are around half the price of landfilling. Now, composting is not available in every city, but more and more it is, and I think this will increase as the world becomes more aware. So We believe that we can save between $3 and $5 million a year in Providence if we achieve waste optimization in our acute sites. So it depends on strong partnerships between EVS, that's environmental services, clinical divisions, vendors, leaders. It's complicated. This is just a quick overview of waste streams, and if you are working in a healthcare facility or have had some experience, what I say to people is you need to understand this. So because segregation is up to us, and if we are clinicians at the bedside or in our offices or wherever, it's up to us to put it in the right place. No one's going to clean up after us. No one's going to go back through the waste and put it in the right place. There becomes some sort of weird assumption that if there's a waste bin and it has a label on it, well, then you can put anything there. It's just not true. And I know that everybody's busy, and I know that this seems like not a big deal, but it is a big deal. This is part of our practice. This is the final step, really, of our practice. So this is important to understand. So we're not going to go into all these streams because your bins and your signage will be different wherever you work, but these are the general categories that we talk about in waste optimization. I mentioned before that recycling and compost is often less expensive than solid waste. You can see that regulated medical waste is more expensive and hazardous waste is the most expensive. This varies pretty broadly depending on your contract and where you are, but these are averages taken across multiple sites. This is just to give an example of two different hospitals across a 2-year period, and or I'm sorry, 10 hospitals. This is the average of one of our health regions in Providence, looking at 2018 compared to 2019. So we normalize waste data by adjusted patient day. You can normalize it by other things like FTE or square footage, but adjusted patient day seems to be a pretty good one for us. And we track total tons of waste, total cost of waste, and then we calculate the pounds per adjusted patient day. So you can see we dropped from 21.8 to 18.8. That's great. And then you can see the landfill rates, the RMW, which is regulated medical waste and hazardous recycling and composting. So the big shift was landfill. The landfill went down, and the percent recycling and composting of the total went up quite a bit, 22 to 20, almost 25%. And so these numbers at the bottom were that if each site of these 10 performed at the average, they would have saved 1,200 tons in 2018, 1,600 tons in 2019. And more importantly, if each site had performed at the best, so equal with the best site of these 10 hospitals, would have saved almost 4,000 tons and close to $1 million just in those 10 hospitals in 1 year. So source reduction, I've mentioned before, is really important and really hard. This is where the social consciousness transformation comes in, the way I see it. So the waste we avoid in the first place is the best way to reduce waste. And this happens in our home lives as well. Just don't bring it into your house. Just bring in less into healthcare. We have in healthcare a knee-jerk reaction to over-prepare and to have redundancy. And that's important. It's important to be able to provide safe care no matter what. But there are ways to do it, to have it be available, but not already opened or in use or primed or whatever. And we can do that through efficiency and efficiency training. So we have many opportunities to reduce waste in clinical settings. Single-use device reprocessing, if you're not familiar with that, that is a process that was introduced and allowed by the EPA in about the late 80s, early 90s. And they listed a number of items that were intended by the manufacturer to be single-use devices, SUDs. But they said, no, these can be used more than once as long as they are cleaned, inspected, repaired, sterilized, or the degree of sterilization required, repackaged, and then can be sold back to the organization. And it's usually at about half the price. So this is a real cost savings method. Many millions of dollars a year are saved doing this in Providence. And also it keeps significant amounts out of the landfill because some of the items can be used up to 10 times, reprocessed and reused up to 10 times. Some it's more like 5, a few it's 2 or 3. But if we can do that and save money, why wouldn't we? It's demonstrated to be safe and effective, and really it's highly regulated and very tightly quality controlled. We can reduce waste in construction projects. This works with our vendors, but construction projects, which are always happening in healthcare, create an enormous amount of waste. We have as part of our policy that 80% of that will be recycled of construction debris. But that depends on the vendors. So that's something that has to be signed into the contract and then tracked so we can stay on top of that. Food waste I've talked about before. It's an important area, and about between 16 and 18% of hospital waste is considered food waste. That's kind of astonishing. Similarly, donations is another way to get after source reduction. So if we have excess of anything that we don't need to throw away, but we could donate to someone else, that keeps it out of our waste stream. So food to food banks, furnishings to secondhand sellers or Habitat for Humanity sorts of places. Community members may be using some of these items. We donate to our Global Partnerships program, which sends high quality, unopened, non-expired medical supplies that we are not going to use and we would throw away, which is an indication of wastefulness. But they need them and they can use them. So we have a process that's been in place for 30 years that we ship that to those in need. And then for some items that don't qualify for that level of donation, we found that animal control shelters can really use them. Sometimes homeless shelters can use things like toiletries that haven't been opened. And so there are ways to reduce what we actually throw out, the very good, high quality stuff that we throw out. So that's a key intention of ours in Providence. And so we know that to reach our goal of 50%, we have to track that data. That's hard. And that takes time. And that is the mindset shift that we're asking our leaders to do. And so far, we've had some good success. So we're going to keep after this. Our waste optimization strategy is really until 2030. But we've said we would like all the acute sites to have everything in place by 2025. So right now, we're developing the playbook, and we'll be doing action site planning in the next few months. So of course, there are environmental benefits to reducing waste, greenhouse gas reduction being one of the biggest ones to mitigate climate change. Also, less resource depletion. I mentioned in another presentation that from the planetary health perspective, our resource depletion is a big part of what healthcare contributes to. And we can tune it down. We don't have to blow through so many resources, but it takes careful planning and shifting the way we think about our products. Reduction of litter. Litter is ugly for sure, but also as plastics particularly break down into our ocean, soil, and water, it gets into our food stream. It gets into the animals' food stream. It's disrupting hormone balances in animals and plants across our planet. We don't want to do that. And then again, what I've mentioned before about culture change, to really shift from being a disposable culture. We weren't a disposable culture 50 years ago, maybe not so bad even 40 years ago, but we really are now. And so that's not sustainable and something that we in healthcare can do something about. So I've mentioned our Providence commitment, and how does waste optimization contribute to this goal? I've already mentioned that we create greenhouse gases through intensive waste treatment and through transportation. And we want to reduce the total volume that goes to these two sources, landfill and incineration. What that leaves is recycling, compost, donations, and source reduction, essentially. So we want to drive things out of landfill or incineration while meeting the regulatory requirements toward these less polluting or non-polluting, in fact, regenerative locales. So we think our goal for waste is to send less than 50%, as I've said, to landfill incineration, and to reduce greenhouse gas emissions from waste by 20%. We think that will about equate, but we'll see, because we're measuring every month and every year, and we'll be watching this over this decade. So our action plan internally, again, this is another case study really about waste optimization, is collecting all the waste data. This is really hard. It's crazy hard. We just got a dump of invoices, because we do a lot of this from invoices, and it was 16,000 invoices. So that's a lot to go through. We have a vendor who helps us to do that, to scrape the data off of invoices. But it's a lot to keep up with and sort of ground truth. Gap analysis: what streams are missing? Who doesn't have compost in place? Who is not tracking their source reduction? Who is not donating food? So we can help then augment some of those streams. And then by comparing our normalized data, we can see, well, what is really out of whack? Does someone have a very high pounds per patient day or a very low pounds per patient day, which might indicate missing data? We'd have to know what vendor services are available in each community and what does it cost. Develop ministry, that's a hospital for us, a ministry-specific waste program, because our rural hospitals in Alaska don't have the same services as are available in Seattle, for instance. Develop processes with clear instructions. We talked about segregation. This is a big deal and it's hard to do. And we need to work with environmental services, nursing, and other clinical staff. We want to track our waste data at least twice yearly, and we actually track it monthly to establish a record and see trends for change. And over time, people don't always start right here, but over time, and as I've said, we expect by 2025, we will have all the elements in place, including tracking donation, source reduction, and reuse. So again, this is achieving best practice in waste management. This is the same slide I showed earlier, meeting our target waste volumes for waste multiple streams, segregating properly to meet these two goals, compliance and environmental goals, while saving money and working together with others, which is necessary for success. Thank you very much. And here's to reducing waste wherever we go.